Bismillah ar-Rahman ar-Rahim. I would like to welcome you all to our surgical retina session today, how to flatten this macula and the macular detachment we are going to discuss in different scenarios with our eminent professors in the field, Professor Dr. Ashraf Sha'rawi, Professor Dr. Hassan Murtada, Professor Dr. Mustafa Nabi, Professor Dr. Shrif Mbabi, and Dr. Shrif Shita. And finally, we will raise the issue of macular shift and functional versus anatomical success in such cases. So first we will discuss the rhegmatogenous retinal detachment, and I would like to ask Dr. Mustafa Nabi, please. This is a case of rhegmatogenous retinal detachment that we have every day with a superior tear in with some vitreous hemorrhages. So how do you approach such cases, and do you remove the flap for a flap tear to convert it into a rounded one? This is mandatory in such cases?
I always think of the feasibility of doing a buckle for all detachment.
It was very turbid media due to a vitreous hemorrhage that I have removed early in the surgery.
Okay, you aim at removal of all traction around the tear, so you have to remove the flap and attach vitreous and even the rolled edges of the brake.
Okay, and do you tend to do a peripheral shaving at this step, or do you postpone it after flattening the retina with a PFCL or at the fluid air exchange?
No, I do shaving early, not after flattening.
And do you prefer to use a PFCL in such a case, or do you drain from the main tear while doing a fluid air exchange?
I drain from the main tear, but if I find much residual fluid, I tilt the eye towards the direction of the tear, perform fluid air exchange. In many cases, I drain almost all fluid, but if not, I instill perfluorocarbon after performing as much as I can of fluid air exchange.
Yeah, and in such a case, we have these two tears that you are going to laser, or three tears, and we have more suspicious area in the periphery like lattices. So they are adjacent to the main tears. So do you prefer to do the retinopexy to the tears and suspicious area only, or do you prefer to do like a barrage 360?
No, to suspicious areas only, tears and suspicious areas.
So this is enough in such a cases, and no fear that other points will open a tear or a detach, so you want to do it like a prophylaxis?
No, if I have done a good shaving of the vitreous base,
This is enough.
I'd rather leave the retina healthy, because laser spots in themselves have the potential of creating breaks at their sides.
And do you tolerate some submacular fluid at the end of the surgery, or do you prefer to leave it like bony dry?
No, definitely I tolerate some. And actually, what you think is bone dry is not bone dry. If you perform an intraoperative OCT, you find still subretinal fluid at the macula.
Okay, Dr. Hassan, please. This is a case of an 8-year-old child that was presented for cataract surgery, and he was delayed and accidentally presented late with this detachment and a giant retinal tear. So what are the key steps in managing a giant retinal tear in such an age group?
You said 8.
Yes.
In this age group,
Can we use the microphone, please?
at this age group, the posterior hyaloid is usually attached, or mostly attached, and you have to manage the posterior hyaloid. If it comes easily, then you are lucky, but if not, you start peeling the posterior hyaloid from the posterior pole, and then after freeing the posterior pole, you inject perfluorocarbon to stabilize the posterior pole, and then you start peeling the posterior hyaloid. You may need bimanual approach with 2 forceps, or a forceps and vitrectomy probe. And
in this case, it was detached completely, and I was lucky. Is it
Yes.
important to remove the anterior flap in giant retinal tears?
Yes, it is
Is it
important.
mandatory?
Yes.
Okay.
In my opinion, this is important because the flap is a functionless retina, and it may act as a source for proliferation over the ciliary body, and maybe a cause of postoperative hypotony and because it may induce proliferation of the ciliary body, strangulating the ciliary body.
And do you tamponade with a silicone or a long
Yes,
term?
and,
Silicone.
and this age group,
Yes.
and with this aggressive pathology, I would put silicone oil from the very beginning.
Okay. So the next case is, and do you suture all sclerotomies?
Yes.
In-
When silicone oil is injected, I like to suture the sclerotomies to
Whatever
avoid
the age.
the ugly appearance of the
Whatever the age group.
whatever the age group.
Okay. So the next case is Dr. Ashraf Sha'rawi. Please present your case. Don't splash the waters.
Yeah, this is a case actually of a giant retinal break which had presented in one-eyed patient. And this is the still picture of the eye at the beginning of the surgery. And the regular routine for me to do the surgery is to do the vitrectomy, trying to unfold the edge of the giant retinal break, doing vitreous-based dissection, even using frequent staining of the vitreous, and then injecting of the perfluorocarbon while stopping the infusion. And as you can see, the retina is being flattened. At this stage, there is no infusion inside the eye. The infusion is zero. And then increasing the bubble, and the important part of it is to increase the bubble inside the original bubble so you don't get fish eggs. At this point, when the infusion came into the eye, it did splash the perfluorocarbon. As you had seen, there were multiple small bubbles of the PFC that had emerged from the large bubble of the PFC. Then application of the laser. I usually do direct PFC silicone exchange. This is my routine. I don't want to go to the hassle of doing exchange between the PFC and air and running the risk of slippage of the break. And I was satisfied with the surgery at the end, and I'm pressing the periphery under the silicone and seeing that the retina is flat and everything is okay. And at this point, I'm doing laser to the edge of the retinal break. As you can see, I was so lucky because the bubble of the PFC didn't go all through to the fovea, but actually it was down and temporal. The patient was photographed like 3 months following the surgery. Still the bubble was there, no reaction around it. And now this is the point to raise about the splashing of the water. And again, the other point, what you are going to do with this bubble during the stage of silicone oil removal. Thank you.
So the next case is Dr. Sharif Shita, please. This is an 8-year-old child that experienced a head trauma like 4 weeks ago, and he presented with this giant retinal tear and doing a vitrectomy and trying to flatten this extensive giant retinal tear with the PFCL bubble. Then we found that the tear is almost oral in this phakic patient, and on trying to do a fluid air exchange, we got this extensive or massive slippage in most of the retina. So how would you manage such a complication intraoperatively?
أنا مش فاهم اللي حصل بالظبط يعني. أنت
This is a
بتعمل
giant retinal tear,
in
yes.
an 8-year-old child.
Yes,
وأنت
received
بتعمل
that trauma and I did a vitrectomy, and on trying to do a fluid air exchange after flattening the retina with the PFCL, I got this slippage.
اوكي. الحقيقه انا زي دكتور اشرف ما بعملش الفقره بتاعت الهواء ثم يعني بعمل دايركت سيليكون بيرفلوركاربون اكسشينج عشان السليبج. لكن لو حصل سليبج هرجع ميه تاني من الاول وابتدي احط بيرفلوركاربون تاني، افرد الشبكيه تماما واعمل دايركت سيليكون بيرفلوركاربون اكسشينج.
And it works, and you do the laser retinopexy at the end,
Yes.
and everything is managed.
Yes.
Okay. So this was managed as Dr. Sharif just said, and I shifted at this step back to direct PFCL silicone exchange, and as we can see, this is the last piece of the PFCL bubble, and fortunately this case improved. As we can see, the Optus image, and this is silicone oil, and this is the appearance 1 week post-operatively with the flat retina. So, Dr. Imbabi, this is a case of a 79-year-old cardiovascular patient that presented with this rheumatogenic detachment and was planned for doing a buckle. But because he is on antiplatelets, he was postponed for 1 week. Then he presented with this choroidal detachment and macular as well. So, what is your approach and how will you place the trochers in such a choroidal detachment? And is there any precautions in such a vitrectomy?
Of course, I would like to do an ultrasound before the surgery if I notice choroidals, because I would put my infusion cannula in the quadrant with the least elevation of the choroid. If it is high choroidal detachment, I would put the infusion in the anterior chamber because I wouldn't risk to induce further suprachoroidal infusion.
If like this case, it's just the one quadrant and it is not that high.
I would go into that quadrant quite anterior and make sure that it is inside the vitreous cavity. Before opening the infusion, I go from the other side with a 23 gauge needle, make sure if there is any choroidal tissue incarcerated in the infusion cannula, I have to clean it with a sharp.
And would you drain in such a case, or you can manage without draining this
No,
choroid?
it usually flattens once you build up the pressure inside the eye, and I try to work on high pressure because it's very easy for the infusion cannula to slip again under the choroid. And the other thing, I will try to be very quick in order to induce posterior hyaloid detachment, make sure that the posterior pole is clean, and I put a perfluorocarbon bubble there to flatten the retina. And with the flattening of the retina, the choroidal fusion flattens with it.
And if we put a PFCL in the presence of this hump of the choroidal detachment, will it flatten the retina over this choroidal?
Yes, and also the choroidal, because it's a fluid, usually it flattens significantly, but we always think of post-operative silicone underfill. So those patients...
This is an upper quadrant zone.
But usually can happen anywhere, inferiorly. The other thing, once there's a choroidal detachment, this means this patient was going into uveitis hypotony syndrome. So this patient is a potential patient for PVR. So I would go even ILM peeling in this patient because they can develop very ugly macular puckers.
So the difference...
مصطفى ممكن
Yes, please.
انا بس كومنت على انك انت العين تاجل اسبوع عشان بياخد انتي بليتلتس. اعتقد ده مش مبرر.
It was the decision of the anesthesiologist.
يعني الانتي بليتلتس نوت ا كونترا انديكيشن فور سيرجري اطلاقا يعني في العالم كله ما حدش بيوقف حتى الانتي بليتلتس عشان العمليات التقليديه. فده مش مبرر لان الهايبوتوني بيزيد والكرويدال ديتاتشمنت زاد من فتره الانتظار. فده ما كانش مبرر ان هو ينتظر اسبوع عشان الانتي بليتلتس.
Actually, antiplatelets are not a single family. Like the Marivan, you have to stop it like 5 days and you have to shift to another drug.
كليكسان
Yes. So it wasn't my decision, it was the decision of the anesthesiologist to perform even a pneumatic under sedation. So he said that the ejection fraction is 25. If anything complicated, he would turn into a general anesthesia. So you have to postpone this, return back to your cardiologist and come with this appearance. So I myself would do the surgery on the same day. But
You do all the surgery under general anesthesia?
if it is a buckle, yes.
But it's not a buckle, I mean.
I was planning to do a buckle.
Okay.
So why it was postponed.
I mean, even a buckle can be done under local
But
anesthesia.
I myself, I wouldn't receive it for myself. Yes, please, Dr.
The presence of choroidal detachment actually does not negate performing a buckle. I think you can perform a buckle. It's a minimum intervention with a much less probability of producing post-operative PVR than vitrectomy. If you put a radial buckle here, even without a retinopexy and a small air bubble from inside, you close the tear, you raise the pressure, you break the vicious circle of...
How I will do the retinopexy? I couldn't apply a cryo over the tear that is present over the choroidal detachment.
I said even without a retinopexy. A thermal surgery. And later on you can do laser retinopexy.
So, Dr. Shetta, this is a case of recurrence. I'm sorry.
Just one single comment about the blood thinners. As Professor Shetta, I agree with him. Most of the patients you can do the surgery on antiplatelets and without. But I have experienced 2 patients that were on antiplatelets. The surgery was perfect. Everything was perfect at the end. Next day, the patient had hemophthalmos. And that was devastating, and I had to go once and twice because just he had blood thinners. So it's unpredictable. It can happen once in a blue moon, but if it happens, it will make you always think to stop I'll always shift to Clexane and I can postpone the surgery. The second point about Dr. Mustafa's opinion, I don't like to do buccal on hypotenuse eye.
Yes.
The chances of choroidal hemorrhage is great, and the patient is already going into uveitis, so I'm increasing the chances of PVR. So I would like to go more radical and do a vitrectomy.
Dr. Schroeder, this is a case of recurrence after doing vitrectomy in another place, and I have no history about it. So he presented with this almost total detachment. So how would you approach such a case?
revision of vitrectomy, if there's leftover vitreous وغالبا ده اللي هيكون موجود, I do a radical vitrectomy, identify any open tears or untreated tears and treat, and then do a
If you
PET-CT.
cannot find any tears after flattening and no Schlieren sign, you can't find any tear, would you inject a subretinal dye, or would,
No.
because I did it before and everything went blue and I couldn't find the tear. So how would you proceed? No tear, and there is no subretinal fluid, and whenever you remove the PFCL, it comes again and you can't find the tear.
Scleral indentation with the
I
chandelier.
did all these.
With the chandelier, and if I don't find tear, I do 360 laser photocoagulation.
And you do a posterior retinotomy to drain?
If you do perfluorocarbon and the fluid goes away, so there should be some peripheral tear.
Yes,
that
sure.
is
Yes,
undiagnosed.
this is what happened, yeah.
Then so you drain the fluid and do endo laser 360, and maybe you put a band, an encircling band to support the peripheral part of the
And
retina.
in such a case without an identified tear, what tamponade would you go for?
It depends. If there is no PVR, I will do gas. If there is PVR, I'll do silicone oil.
So I did like what Dr. Sharif said. I didn't find the tear, but differently I did a posterior retinotomy drain and did a peripheral retinopexy and barrage, and this case was left on gas tamponade. So we'll shift.
You have to revise for this case in which you didn't detect.
It is not my case.
Oh, okay, you have to revise the diagnosis. Maybe it's an exudative retinal detachment and not a rheumatogenic retinal detachment. If you don't find any retinal breaks.
Could be. So we will move to a macular hole detachments, and this is a case of Dr. Hassan. Dr. Hassan, please tell us how you would fashion your eye lamp flap in such a macular hole detachments.
Following a removal of the posterior hyaloid, which is also a very important step, and you have to use triamcinolone, and sometimes the posterior hyaloid becomes more obvious and more highlighted by the blue dye. I start the eye lamp peeling to fashion the multi-layer flap while the retina is still detached. And I start usually just central to the inferior arcade, and then moving the flaps toward the macular hole, exerting no traction over the macular hole. The idea is not to lose the contrast, because as you see, the posterior pole is white in color, and if you flatten the retina, you will lose the contrast even with the use of the blue dye.
Is it important in such a cases to do a 360?
360
or a temporal flap can work?
No, I'm pro multi-layer flap, especially in the myopic eyes. This is a point of debate and controversial issue, but I'm with the multi-layer flap in myopic macular hole detachment. And once the flaps are created and identified, then you can attach the retina with perfluorocarbon and complete the peeling of the eye lamp to create the multi-layer flap.
In such a cases, do you counsel your patient of a lower incidence of closure? Do you mention that you have?
No, the closure with the multi-layer flap is almost 100%.
Even in this myopic?
Even in this myopic eye.
And the atrophic choroid.
This is the advantage of the multi-layer flap over any other technique.
If unfortunately you got a case of persistent macular hole, what is your first option?
I haven't encountered a case of persistent macular hole following this technique. Never.
Okay.
I'm waiting for a case of failed macular hole to see what I will do. But I really and honestly never encountered a case of failure. So this is the multi-layer flap placed over the macular hole. Perfluorocarbon is exchanged with air and not gas. I don't like to use silicone oil in myopic eyes, except when there is PVR, because of the high instance of glaucoma, because these eyes are potentially glaucomatous.
Okay, Dr. Sharif Mbabi, this is another case of a macular hole detachment, and I would like to have your opinion about how you would clean all premacular proliferations and vitreous cases in such myopic patients. Do you prefer to add a triamcinolone early, or do you depend on BBG?
No, triamcinolone is mandatory, not just in high myopes. In every case, I use triamcinolone because vitreous cases is very common, even in non-myopic eyes. So I usually depend on triamcinolone. This is the most important step in myopic macular hole detachments is to remove the posterior hyaloid. Because if you don't remove the posterior hyaloid completely up to the aura, the patient will develop PVR and recurrent detachment even if you close the macular hole. So this is number one. And then number two, once I have a clean retina, and I'm sure that the vitreous cases is completely removed, then I stain with brilliant blue and I peel the ILM, as Professor Murtada mentioned, on a detached retina. And I do it very meticulously and I take my time because the ILM is very fragile and you want to keep the inverted ILM flaps, because if you lose the flaps, the hole will still be persistently open.
Dr. Hassan, do you feel that BBG is a good stainer for these multi-layers of the vitreous and the premacular proliferation?
As Dr. Sharif maybe said, triamcinolone maybe is sufficient, but you have to look for remnant of the posterior hyaloid under the blue dye,
Yes.
whatever the blue dye. What I would like to add, if this is a case of myopic foveoschisis, is it Yashri?
No, this is my case. It's a myopic macular hole detachment.
Macular, okay. So I would go also for a multi-layer flap.
I did like
noticed that
360,
you have
yeah.
removed the,
I have removed all the premacular and did a
yes,
360.
but I think the eye lamp in these cases is a fortune. So we have to
Yes, sure.
preserve the.
Sometimes in such cases, I try to perform this 360 without the use of PFCL, Dr. Sharif Shetta, because as Dr. Hassan said, the choroid sometimes is white and it may hinder your peel. And the other thing is it's a long eye, because one time I experienced that the retina is resided back and the eye lamp was very far and my eye lamp peeler could not reach this area. So do you have this?
طبعا يعني مشكله اللونج اكسيال لينث ديت ليها حلول. من ضمن الحلول انك انت تستعمل اكسترا لونج انسترومنتس بتوصل للبوستير بول. من ضمنها انك انت تستعمل عدسه اللي هي بيسموها الفيرسا لينز، عشان انت عاده بتحب تخش فيرتيكال، فبدل ما تفضل تخبط في العدسات انك انت ممكن ما تحطش تروكر او ممكن ترجع بالتروكر لورا اب تو 6 ملم في الهاي مايوبيك اي، لان الاورس الرتا بتبقى بوستير، تعمل ترانس اليمينيشن وتعرف مكان عشان تقدر توصل. ففي الاخر بتجد حلول وتقدر توصل لورا. بس المشكله الستيننج انها بتبقى فيري فينت في الهاي مايوبس، وبالتالي انت يوجوالي بتحتاج مالتيبل ستينز اكتر من مره عشان تعمل ستيننج. وزي ما قال الدكتور حسن انا بفضل انيشيت الستين ان ديتاتشد ريتنا، وبعد ما اعمل فلاب بحط البلوفروكارب عشان تفاشن الريست. انا مش من انصار المالتي لاير فلاب الا في حالات المايوبيك ماكلر هولز، فعلا دي بتدي نتائج احسن كتير.
دكتور اشرف, how would you drain such a detachment, or you don't drain?
We have to revise again the picture of this detachment. This detachment is extending up to the periphery, and it should not be considered a myopic macular hole detachment.
There's no other
There
tears.
must be a peripheral break, because
Not other tears.
there must be a peripheral break. And previously in our early eras, we had been doing these cases just by buckle and to close the peripheral break. So you have to search, even if you have a macular hole, you have to search for a peripheral break. And if you don't have any excuse except to drain through the hole.
Okay, I have to move on because of the time. This is the cases of Dr. Sharif Shetta. Please, Dr. Sharif, tell us your
ده شاب صغير عنده كونجنتال اكس لينكد ريتينوسكيسيس وعنده فوفيال ديتاتشمنت، هيوج فوفيال ديتاتشمنت. بالرغم ان البريفيرا كانت كويسه لكن عنده كارت ويل، فعملنا له بوستير هايلول سيباريشن. طبعا السيست ديت كانت عاليه جدا، فبنعمل اي ام بيل. في ناس بتفضل الفوفيا سبيرنج خوفا ان هو يعمل انديوس دي روفنج للفيري ثين ريتنا، بس انا كنت جريء شويه فعملت كومبليت اي ام بيل. واضح ان الريتنا فيري سيستيك هنا اهوت، بعملها فيري تانجنشالي وفيري كوشسلي، وباخد وقتي عشان الريتنا تقشر زي ما انت شايف، بقف كده عشان ادي فرصه للريتنا انها تبعد ميكانيكالي عن الايلم بي. بعد كده بقى السيست ديت بعمل بانكشر ب 41 جيج نيدل واسبريت الفيسكا سب ريتنال فلويد على
دكتور
امل.
شريف الفاكيوم هنا بيبقى كام؟ لان هي صعبه
الفاكيوم
جدا.
450. وبعد كده بعمل فلويد اكسشينج. طبعا يو دونت دو ليزر فيس ريتينوتوم الصغيره، والريتنا اكشوالي بتسيتل اف يو شو ذا بري اوبرتيف اند بوست اوبرتيف. المشكله ان الفيجوال امبروفمنت داز نوت بارل الاناتوميكال امبروف، لان طبعا الوايرنج والكاتنج بتاع المولرز فايبرز بتخلي الفيجوال امبروف. ده انذر كيس اوف اوفيس كيس، بس كان معاه بريفرال ديتاتشمنت وبريفرال تير. هنا بما انه صغير فبرضه بنعمل ترايم سيلولون ونريموف البوستير هايلايت، وبعد من نفس الحكايه بنستين بالبلو داي وبنعمل اي ال ام بيل، وبرضه بتاخد وقتي جدا عشان اعمل اي ال ام بيل فيري كوشسلي وتانجنشال من غير ما اعمل اكزيرت تراكشن على الريتنا. برضه بنفس الحكايه 41 جيج انجيج انتو ذا ريتنا اسبريت السبريتنال الفيسكا سبريتنال فلويد وتريت البريفرال تير باي ليزر فوتوكواجيليشن. وهتشوف البري اوبرتيف اند بوست اوبرتيف بيكتشرز. طبعا الواضح جدا ان السيستيك تشينجز اللي في الريتنا اتحسنت جدا، بس برضه هقول ان الفيجوال امبروفمنت داز نوت بارلل الاناتوميكال امبروفمنت. فلازم ومونيتور العيان ده ونعمل له كونسلنج كويس عشان يبقى عارف ان الفيجوال اكسبكتيشنز. بس هم كلهم ما حسوش بديمينيوشن فيجن، اتحسنوا بس مش بالتحسن اللي كنت متوقعه لما اشوف الاناتوميكال ريزلتس.
دكتور حسن.
I operated on a few cases of foveoschisis, congenital X-linked foveoschisis. I could not dare of peeling the eye lamp over the fovea.
Yes.
Even if you are an excellent surgeon, you go tangential, and there is no value or therapeutic value of peeling the eye lamp over the fovea. So doing fovea sparing vitrectomy in these cases, aspiration of the fluid, as Dr. Sharif showed us, may result in some visual improvement. This is not consistent.
Okay. So, Dr. Ashraf.
My question is for Professor Sharif. Why you did drain the subretinal fluid from the area of the papillomacular bundle? Why you didn't go externally to the temporal area?
It could be، بس يعني في الحالة دي الريتنا very elevated، وبالتالي البنكشر دي does not disrupt البابيلوماكولار فايبر زي ما حضرتك متوقع، وبالتالي you can do that. بس أنا حبيت اللي هي الموست accessible area بالنسبة لي، إن أنا والموست height elevation إن أنا أبنكشر فيه.
Does anybody give a chance for carbonic anhydrase inhibitors, topical carbonic anhydrase inhibitors for such patients before we do surgery? And the other thing, for Professor Sheta, since you noticed that the visual improvement is insignificant, when you have a future patient, would you still operate on him, or you just give him carbonic anhydrase inhibitor and follow those patients?
في الواقع العيان ده أنا اديت له لأنه كان عنده بايلاترال، فاديت له كربونيك انهيدريز انهبيتور توبيكال فترة طويلة وما تحسنش إطلاقا. and I counseled him. هو قال لي I will go for surgery. ولما عمل الجراحة قال لي أنا شايف بالعين اللي عملت فيها الجراحة أحسن من العين الثانية، بالرغم إن هو anatomy يعني باللاينز ما تحسنش كتير، لكن function اللي تحسن.
دكتور مصطفى, this is
I would do it again.
This is a case of 38-year-old male that had a head trauma a week ago while playing football and presented with recent diminution of vision. And as we have seen in the OCT, there was like a neurosensory detachment with an impending full-thickness macular hole and an optic pit. So would you observe or would you operate in such a case?
Actually, I didn't see the OCT. I didn't have.
This was the OCT. Did you see it?
No. Yes. Actually, this is not due to trauma. This is the optic pit detachment, a typical one. And usually I give some chance for improvement, like 1 or 2 months. Then, if not, I operate by vitrectomy and ILM flap closing the optic pit. But I don't peel the ILM on the fovea. I peel it in the upper nasal retina and take the flap, close the pit,
So,
leaving the ILM intact on the macula.
So I am a good student to Dr. Mustafa, and I'm trying to do what he said, but I'm trying to do like a double eye lamp flap, one to secure the impending full thickness macular hole to cover this fovea that was impending to rupture, except that it has this roof of the eye lamp, and I tried to fashion this another eye lamp flap that I will turn it into a graft to plug it or to stuff it into the optic pit. So Dr. Mustafa, do you stuff anything into the pit, or you just cover it with this flap?
Actually, what I do is I try to drain through the pit. I put my rubber tip cannula. Sometimes I am successful in lowering the level of detachment. If not, I put the flap on the pit, push it very little bit inside with the scraper or a rubber tip cannula.
Would anyone put a plug in such a case? Dr. Sharif Sheta, please.
هو اللي ذكر في البلاجنج او الستافنج ده حاجات كتير، منها بانكتم بلاج، سكليرال باتش. اللي انا عملته
I did a tenon graft in such a
اللي انا
case.
كنت لسه هقول لحضرتك اللي انا عملته مؤخرا وبقيت استعمله في الاوبن ماكلر هولز وفي كده التينونز بلاج.
Yes, it works very well. Yes.
اتس هاندي سوليوشن، وميزه التينون ان ات ستيكس، وبعدين
Yes.
مش محتاج منك تحضير.
Like this.
It sticks، وبالتالي
Yes.
انا شايف ان هو the most efficient and most easy way to plug
Dr. Hassan, please. This is the early OCT after 3 weeks, showing that the neurosensory attachment is starting to decrease after only 3 weeks, and this is after 14 months. And what is interesting, that the eye lamp flap is still present after 14 months, securing against a full thickness macular hole. Dr. Hassan, please.
I usually do exactly what you have done. So I divide exactly as you have done. I divided the eye lamp for the impending rupture of the hole of the macula, and putting a multi-layer flap, and then the other half for plugging the optic pit. I can accept plugging the optic pit with the tenon flap, but I don't accept it for a macular hole.
Okay. Dr. Sharif Imbabi, this is two cases of submacular hemorrhages. One is due to a persistent macroaneurysm after 1 month, and the other one is a wet AMD. So how do you inject a submacular TPA, and do you peel eye lamp in such cases as a routine?
Okay, first of all, I don't peel the ILM in such cases.
Okay.
It's not indicated.
And do you
at
inject
all.
manually or automated?
Automated. I use the machine to inject. I have control from the foot pedal, and as
Pressure injection?
yes, and I use the same needle like you're using 39 gauge or 42 gauge.
And what is the pressure injection or pressure?
I use it. I just go linearly. I just start with a slow injection. Once I find myself in the balloon is forming, I just stay at that pressure, whatever that pressure is.
Okay, and do you inject subretinal air? Is it important?
Usually no, unless it goes accidentally. The other thing I prefer to inject inferiorly and not superiorly, and because I want the fluid to go inferiorly, and I'm very cautious not to go with high pressure, because the most dreaded complication that can happen to anybody, and it happened
Macular hole.
Macular hole, and you see
So-
the blood coming nicely
Yes.
out of these macular holes. And in that case, you have to peel the eyelid.
And do you counsel those different scenarios differently? Because this is a macroaneurysm that it could resolve, and the other one is a wet.
Again, you have. I usually do an OCT in case of macroaneurysms, unless there is a significant. Usually, the subretinal hemorrhage in macroaneurysms is not that bad as in AMDs.
But it persists for 6 weeks.
Okay, and usually there is a big component that is sub-ILM, by the way, or subhyaloid.
The other one is subretinal. As you can
Subretinal,
see.
okay,
Yeah.
I go fine.
I mean, do you when you counsel your patient in a macroaneurysm, you can almost offer the patient a very good result because you are expecting.
Absolutely.
In such a hemorrhage, a dense hemorrhage in a wet AMD, you cannot see whether there is
Usually
a.
the prognosis is much poorer. And
Yes.
my experience with the wet AMDs, yes, you
And you mention it to the patient
of course.
preoperatively.
And actually, at the end of the surgery, I inject an anti-VEGF, because some of those patients, they rebleed again after a very successful surgery. After you.
Dr. Ashraf, please, this is a myopic traction maculopathy, and this is your case. Please tell us how you less is more in your opinion.
Yeah, this is a myopic tractional maculopathy, which a patient which I had been following since 2018, And as you can see, the posterior hyaloid was attached. In 2020, there was start of schisis. In 2022, increase in the schisis and the traction. I didn't operate at that time because the visual acuity was good. However, by the end of 2023, the vision did drop. And as you can see, this is a composite picture of the OCTs in which I followed. Now going for vitrectomy, just staining the posterior hyaloid with quinacort or triamcinolone. And as you know, there are some advocates who see that ILM peeling is a mandatory part of the procedure. For me, I go for less because I'm afraid to get like an induced macular hole, and some go for foveal sparing ILM peeling. I did not go for any ILM peeling in this case, and I thought that this would be enough for the patient. And again, you have to detach the posterior hyaloid up to the periphery, to the vitreous base, to avoid any traction in the future. And this was 2 months later. After 2 years, there was complete flattening. This is the preoperative before surgery immediately. At this point, the vision was like 0.2. And then after the surgery, 2 months after the surgery, the vision improved to look like 0.4.
To move on for the next entity, which is the PVR. So, Dr. Mustafa, this is a case that had 6 surgeries before, doing a buccal, then a gas, vitrectomy and silicone, then silicone oil removal, and then presented to me in such a case with a total retinal detachment, PVR-C, in the macula and the macular hole. So after removing all the premacular proliferation, doing a flap for the macular hole. So how would you evaluate the extent? And definitely you cannot reposit the retina back because of intrinsic shortening. How would you evaluate the extent of the retinectomy that you are going to do in such a shortened retina in the periphery, as we will see in a minute?
If I inject perfluorocarbon on the posterior pole, I find that peripheral retina is still detached. In the area of shortening, it is detached in a flat surface, while in the area of mobile retina, it is detached in the form of bolus appearance. So I go to the area of flat surface and extend at least 1 hour beyond it to be the limit of my retinectomy.
Okay. And what about if you still do your retinectomy and you're approaching the inferior arcade and you cannot remove more of the retina? So would you shift for a radial retinotomy or retinectomy?
Yes, a radial retinotomy pointing towards the disc, because such retinotomies extend.
And you do all
the disc is the limit.
And it's mandatory to do all the retinectomy under PFCL, not under air, right?
Yes, because you cannot predict that this retina is not going to bleed, and you don't want to have blood underneath the macula.
But I mean, it's more safer. Yes, Dr. Sharif Mbabi?
If I do a retinectomy, I would like to do it without air or perfluorocarbon at the beginning, because the last thing you want to have subretinal air or subretinal perfluorocarbon. So I make sure that I have a clean retina, and once I have a clean retina, I put my perfluorocarbon. But I don't like, unless I have a small bubble just over the macula to protect the macula, but to have a big perfluorocarbon and do retinectomy under the perfluorocarbon poses risk of subretinal perfluorocarbon and complicates your surgery.
The retinectomy should not be done under perfluorocarbon. It's done while the perfluorocarbon protects the posterior pole, but not under the perfluorocarbon
Dr. Hassan, this is your case about a chronic detachment and a subretinal band. So do you start all your cases with triamcinolone staining?
Yes, this is the
Microphone, please.
This is a highly myopic patient, and this is actually a one-eyed patient who lost the other eye following detachment surgery, and he was afraid of doing surgery on this eye. And you can see that it is an old-standing detachment. The posterior hyaloid was peeled easily from the posterior pole, and I continued the peeling to the to the posterior border of the vitreous space. There was a strong attachment of the vitreous. There also the eye lamp peeling was not an easy procedure. It was difficult, but with the use of repeated or augmenting the staining, I could peel the internal limiting membrane. The patient had a large posterior staphyloma, so I think that removing the internal limiting membrane would free the underlying retina.
Hassan, did you ever encounter a delayed macular hole in such peels?
No. Although I peel eye lamp in many cases, actually.
Dr. Sharif Mbabi?
You may have a macular hole later on. If the patient, especially if the patient develops PVR post-operative, because this is a chronic detachment. So, so in this case, if it goes well, fine. But if there is a PVR post-operative, sometimes stretching of the macula can have a post-operative macular hole. So it's always a risk there. But of course, if it's a chronic detachment, it's justified to peel the eye lamp, of course.
Yes, I think as a protection for the fovea sparing technique, eye lamp peeling is the safest. And nowadays I'm following this technique in most of the cases.
Why in such a case you decided to remove this subretinal band? Did it hinder the retina?
Because this subretinal strand was so stiff and causing tinting of the retina. So I had to remove the subretinal strand, and it was not removed completely.
Yes.
Just to allow the retina to attach.
And you take the decision to remove subretinal band after trying with the PFCL bubble, right? Not
Yes.
under air.
No, I don't use air. To tell you the truth, I do not use air. I depends on perfluorocarbon in most of the.
This is the second case. This is your second case, Dr. Hassan. And my question here: when are you going to flatten this central part with the PFCL bubble? After ensuring that you did the posterior vitreous detachment, or after removing the peripheral PVR elements?
Well, this is a pediatric retinal detachment, and the retina looks as if there was an epiretinal membrane, but after flattening the central part with perfluorocarbon, I discovered the presence of a taut subretinal strand, and actually it was an extensive subretinal strand, and strange enough, the eye lamp was attached to the posterior hyaloid. So this is the posterior hyaloid, and I discovered the presence of another layer of the posterior hyaloid while I'm trying to remove the internal limiting membrane. Shaving the vitreous space meticulously, and then retinotomy, gaining access to the subretinal space in order to remove the subretinal proliferation. Actually, it was a napkin ring, some subretinal hemorrhage, and then working bimanually with 2 forceps, preferably serrated forceps. And you can see that the subretinal strand was so extensive, and this is the cause of the closed funnel appearance of the detachment. So there was almost no actual epiretinal membranes, but it is due to subretinal proliferation.
Nicely done, Dr. Hassan.
Thank you.
So we will move to the element of, or the title of, traction retinal detachment, and this is the case of Dr. Sharif Mbabi. Please tell us what happened in this case.
So this is a young lady that had a complicated delivery, and she was in the intensive care for some time, and she presented to me with bilateral endogenous atypical fungal endophthalmitis. I tried with her systemic antifungals, did not improve even with intravitreal injection, and decided to go for surgery. Now, as you can see, that there was a big tissue there that was over the macula. Of course, in infections, you don't try to work a lot on the macula, but in this case, I كنت طماع شوية, I decided to peel the element. You can see here, this is the focus, this is the nidus that was the reason for the infection. Despite no breaks was induced, the patient developed PVR and, of course, infection. is a very stimulant for PVR. Again, I trying to flatten this macula, and I did a small retinectomy to remove this original source of the infection, because otherwise it would not flatten the retina.
Sharif, if we have treated this fold in the initial surgery, would this could have avoided?
It was not easy to treat it with the initial surgery with the inflammation that was there.
Okay.
So the retina was flat, and I wanted to remove the silicone oil in this patient, but there was a paramacular hole that is not in the fovea, but it was rather in the lower part of and there is a little bit of wrinkling of the macula. And there was, you can see this break that was not there. The retina is there. There was a little subretinal band, which is expected with this PVR, and I removed this PVR. Now the issue is how to close this hole. I tried to stain. There was no remnants of ILM. I tried to stretch the retina to refashion the retina. There was a little bit of tissue that was there. And now the point is, I don't like to do laser for such a very posterior break that was close to the fovea. So I decided to do an ART, okay? And this usually works, if it works with macular hole, it can also works with paramacular hole. I don't use diathermy. I just use the vitreous cutter to keep the viability of the tissue. And then under peripheral carbon, I just sweep it down there and I just put it over
Would
there.
an amniotic membrane work the same as?
It would work. It would work.
Yeah.
But again, you don't need preparation for this. You already have.
I mean, but you are sacrificing part of the retina.
It's peripheral and it's not important, and the things are quiescent. And this is at the time of silicone oil removal. The patient had vision at post-operative 0.16, which was really surprising. The other eye, by the way, I operated, but the macula was not affected. And she was enjoying 0.8 in the other eye, and in this eye, 0.16. So this is just a combination of all issues that you can meet in retinal surgery: infection, PVR, macular breaks, and out-of-the-box way to close a macular hole.
Very nicely done, Dr. Sharif. Dr. Hassan, please, you want to comment?
Very small comment. These eyes are at risk of always at risk of proliferation. So cutting the retina, especially posteriorly, may stimulate proliferation. So I would go for an amniotic membrane graft rather than, but this is excellent surgery.
So we will shift to tiny paramacular holes with Dr. Mustafa Nabih. So what happened in this case?
This man presented with history of 2 pars plana vitrectomy for retinal detachment. He gave me his doctor's words. You had a retinal grafting. I translated this to an ART graft in one of the surgeries. The eye was oil filled with lower half recurrence, with an open large macular holes and 2 tiny paramacular holes probably resulted during removal of epiretinal membrane in the first surgery. The macular hole is pointed to by the red arrow, the other ones by the black arrows. I started by removal of silicone oil. Then I went to the periphery. There was contraction of retina, peripheral to the area of probably the area of harvesting the first ART. This retina was contracted. I tried to remove as much as possible of the epiretinal membrane in the surgery. There was no way to remove the fibrous tissue except with peripheral removal of internal limiting membrane. Then I took a piece of the peripheral retina, fashioned it small enough to be laid on the
Is it
macula.
important to put the ART in a special orientation?
Actually, I try as much as possible to put it in the right orientation, but if not, I don't do much to.
Yeah, it's
to
a plug
correct it.
anywhere. Yeah.
Yes. This is the post-operative OCT. It was good for first week. Then fluid started to collect once more in the lower retina. You can see that the autologous retinal graft is adherent to the retina, but the fluid came from the tiny hole that was not treated. Tiny holes are said not to be treated because they don't have any traction, they don't cause any detachment, but in this case they did. I reoperated under silicone oil.
Do you usually operate under silicone, Dr. Mustafa?
In most of the cases, yes.
Okay.
Only 2 sclerotomies, drainage of fluid through the tiny hole, then applying laser. here there are two sclerotomies. This is the post-operative appearance, OCT, showing that the graft is integrated in the retina. Very good layering, and the visual acuity was 0.2, much improvement of vision.
Nicely done, Dr. Mustafa. So, about the issue of vitrectomy under silicone, who do it frequently, Dr. Sharif and Babi? In a show of hands, who do vitrectomy under silicone? Dr. Mustafa? Dr. Mustafa only? Dr. Sharif, please, yes.
No, I don't work under oil. I prefer to remove the oil, reassess the retina as if it's a new case. I don't want any bleeding under oil. I don't want any remnants to be, because you want a radical solution. You don't want to go again inside the eye if you, maybe there's a need to more vitreous-based shaving, retinectomies, and so forth.
This is a 60-year-old that had a vitrectomy and gas, then recurrence under silicone with this intrinsic PVR. So I decided to try to do it under that silicone oil and trying to do the retinectomy, so the silicone inside the eye would support the retina and help me to design the extent of the retinectomy, because when I do it under PFCL, sometimes I may resort to do a lot of radial retinotomy because it's very close, as we will see when this retina reside back, it's very close to the inferior arcade. And I have witnessed a surgeon in England that the retinectomy went inside the macula. So after removing all the intrinsic PVR, the retina resides back, and just by adding more silicone injection with the VFC mode and doing just a passive aspiration using the flute needle, the retina went back in its place and there was no silicone as I imagined under the retina, and I have not to remove this silicone and just augmented the silicone that was present in that time. And I did the laser nicely over the whole edge of this large tear, because it was a fibrotic and dead retina and very ischemic. I did the laser very well, and as I was just saying, if I did a extensive retinectomy under a PFCL, I would have reached the inferior arcade. And this is the appearance under definite closure, and this is 1 month after the surgery and 4 months at the time of the silicone oil removal. And this is the appearance of the retina, very stable and very nicely attached without any recurrences in such a case. So Dr. Mustafa, please.
Actually, working under silicone oil gives a lot of advantages.
Yes.
It's a very stable
A
environment.
third hand, yes.
Yes, and if bleeding occurs, it's actually much less and more localized than if you have fluid inside the eye. And even if you want to push fluid from the posterior pole anteriorly, you can put a bubble of perfluorocarbon underneath silicone oil.
Yes. So I would like to ask your opinion. Who would do a vitrectomy for such a case with a 54-year-old myopic patient, had LASIK and hand motion vision 1 day ago, with these multiple tears and this inferior tear as well in an attached retina? Who would do vitrectomy? Dr. Sharif. Dr. Hassan. Who would do a buckle? Dr. Ashraf and Dr. Mustafa. Okay, so this patient received a buckle on the same day, and this is the appearance on the third day, with and the inferior tear was already buckled with the band. And interestingly, in such cases, the vision improved very rapidly on the third day, and this is the beauty of the buckle, which is like a LASIK wow effect, that the vision regained very early compared to vitrectomy cases. So this will take us to the next topic, which is the macular shift. Which is important for us? Is it the anatomical reposition or the functional success? And this is my question, because in such cases of retinal detachment, this is a case of superior tear with a retinal detachment, underwent a vitrectomy, and I put a gas and everything went well. But on doing the follow-up Optus images and red-free images, we found that there is still some vascular shift starting to take place. This is the 3rd month, this is the 6th month, this is the 9th, and if we can see by the end of the year there is a massive change. And even the rotation in the second picture, you can see that the arcades are shifting the whole way downward, compared to the buccal case that we had seen, that the vessels are still present in the 3rd month, 6 months and 9 months, and by the end of the 1st year it's still stable in the same place and with no shift. And when they tried to analyze why this shift happened, they found that on the step of doing fluid air exchange, and even when we asked the patient to take a face down position, you shifted the fluid from the upper part and you stretch the retina under this moving fluid to the inferior retina, as we will see, and this will definitely reflect on the cone mosaic, and this is the cause of what patients report after doing vitrectomy, especially that they report that there is an anisoconia, that the objects come smaller, come larger, because this change in the position of the retina and the retinal vessels and the change in the mosaic of the cones. So my question here, if a case is amenable to be treated with pneumatic or a buckle, would you consider doing this treating procedure just for allowing a more physiological attachment of the retina, starting with Dr. Sharif Mbabi?
Well, the decision to do a buckle or a vitrectomy, I don't like pneumatic retinopexy. My experience is just with only localized fluid. But a buccal vitrectomy, you have to look at the indications. Now, the last thing you want to have is to do a buckle and you have a recurrence or a persistence. Sure. So this is very annoying to the patient and to yourself. So I do buckles only if I have a single break, or a lattice degeneration in one quadrant that I can buckle easily. But if I have multiple breaks in different quadrants, I would not like to do a buckle because there is a chance of failure in those cases. So the most important thing for us is the anatomical success. And then the function comes after that. Because if you don't have an anatomical success, you don't have function.
Sure.
That's very important.
So it's according to surgeon discretion.
I'm saying that buckles are still, I still do buckles a lot, but I select my patients.
Sure.
So if I do proper selection, especially in children or young patients with lattice degeneration, good healthy vitreous, it works beautifully well. But if you have a turbid vitreous, multiple breaks, pigment cells a lot, okay, in this case, there is no point of doing a buckle. Unless you're taking a risk that will probably you will pay dearly.
No, my question is, definitely buckle is a safe procedure to do in such a case. So would you consider doing this, name it like a conservative procedure compared to vitrectomy? Because you have the sense that it will allow a more physiological reposition of the macula?
I'm not aware of a study that says that buckles gives better
Pneumatic is better than vitrectomy in the pivot study.
Okay, but in our hands, you have patients that see 20/20 after vitrectomy.
Sure, but I have patients with vitrectomy that's complaining after 20/20 with anisoconia, but not in buckles. This is my question, Dr. Okay, Dr. Sharif.
I assure you, I can show you folds after scleral buckles. So
sure. No, this is fold.
Shifting of the retina can occur even after scleral. It is much less than vitrectomy. بس حتى في الفيتركتومي لها حلول. الشيفتنج اللي حضرتك بتقول عليها او الديسبليسمنت ده، لكن انا في رايي اللي بيحدد الفيتركتومي او باكل مش حاله الريتنا، انما حاله الفيترس. انا بحب اعمل باكلز، لكن لو حاله الفيترس اجريسيف وفي باتش فيترس تراكشن، ديفينتلي انك انت تادرس المين سورس اوف تراكشن هو الاساس.
دكتور مصطفى بليز.
Actually, of course, many factors decide whether to do a vitrectomy or buckle, but if the conditions are ideal for both, I prefer a buckle because many studies shows that the functional improvement after buckling is better than after vitrectomy, despite equal anatomical attachment rate. Moreover, the displacement, the rapid reattachment of the retina, hydraulic reattachment, whether with air or perfluorocarbon, induces misplacement or misalignment of the photoreceptors, while the gradual absorption of subretinal fluid in a buckle gives the retina the chance to regain its original alignment.
Dr. Hassan, please, in 15 seconds to allow Dr. Ashraf.
First, I do not trust pneumatic retinopexy.
Okay.
So this is not my favorite technique. Buckles, if I have a single break, localized detachment, fresh detachment, I go for buckle. But with multiple breaks, I cannot guarantee whether the buckle will be successful or not. And the case you have shown us with multiple holes, and some of them are posterior. breaks.
No, this is the optus image that enlarge the periphery. This is not posterior.
If I have a posterior,
No, definitely
hole
if
of
posterior,
opus,
yeah,
then
definitely.
you have to go for vitrectomy. If you have multiple breaks, then you have to go for vitrectomy.
Okay.
So if you have success in a case with multiple breaks with a buckle, then you have to go to put your buckle very posterior, which is traumatizing to the globe and carries the risk of complications from insertion of the suture. And regarding the shift, there is shift whether you with the buckle and with vitrectomy, and more with the vitrectomectomy.
Probably.
Of the retina, because you are forcing this retina to become attached with the bubble. So I think comparing the three techniques, it depends on the case, it depends on the preference and the technique that works best with the surgeon.
I'm sorry, I have to conclude. Dr. Ashraf, please, rapidly.
For sure, if you have a case which is suitable for buckling, buckling is the best, especially if you are using the chandelier buckling.
Thank you very much. It was my pleasure to have you in this session, and thank you for your attention. Thank you very much.